sex, gender, and health perspectives from South Asia. So we all know that in South Asia, that conversations or even discussions around sex and gender is pretty much a taboo and it's a stigma. So this book is offering a really different perspective and the challenges that are there on ground. There are speakers who have been advocates of these issues, and we've seen how these issues affect lives of women in South Asia from all parts of South Asia. This is like a multidisciplinary compilation of chapters addressing issues on health. And it's an in-depth exploration of how intricate these issues are in people's lives. So it is in the context of a broad context of how this plays out in the broad social and cultural context of South Asia. So we're extremely honored to have the authors here for today. So together, their reflections will give us a sense of how this issue actually plays out. So first, for the introductory remarks, I would like to welcome Dr. Mrudul Ippan. She's a honorary fellow of CDS. She has served as a member of the Kerala State Planning Board. She's known for her work on gender, labor, and development issues, particularly in the context of Kerala's model of development and gender responsive public policy. I would like to invite ma'am for the introductory remarks.
Yes, yes.
Yes.
I cannot see above. Or can you open it fully? That might be a better thing. Yeah. Good afternoon to all, and a very, very warm welcome to the editor of the chief editor of this volume, that is Sundari, and other editors. I don't know if any other is present. I don't think so. Miss M. Shivakami, Anjana Bhushan, Sabina Faiz Rashid, Kausar S. Khan. They're online. Okay, so welcome to all of you all who are online and all those who are offline. Now, all I can say about this book from my gut is that it is a phenomenal piece of work. I mean, absolutely no doubt about it. A phenomenal piece of work. And perhaps for me, because I had been a little bit familiarized with this whole issue of gender and health. So for me, and I don't know if the authors also look at it the same way, it is a culmination of the relentless effort, commitment, passion, energy, with which some of the stalwarts as health scholars, stalwarts of activism, um, were actually trying so hard to inform the need to bring on board discussions on health disparities arising from sex, gender differences. This was a very, very concerted effort on the part of the stalwarts, as I call them, and most of them, quite a few of them came from Kerala, from CDS itself. I'm not naming any because I know I'll forget some names, but we know who the stalwarts are. And so they really made an effort in somehow sensitizing policy and society and polity to the whole issue of health disparities being on account of sex and gender differences. Now, sex and gender differences, of course, one thing I'll just come to what the book is trying to, how it's trying to explain all this. But for me, sex and gender, the one problem which I find is sex, of course, is, we all know, the physical manifestation, and gender is more socially constructed. But sometimes what happens is, because of your sex, also gets, it overlays the gender issue also. The most common and the most important thing, of course, is the whole issue of childbearing. Because you bear children, you also have to look after them. So your major role is, your primary occupation is looking after children and household work. So they then get sort of interlinked. Now, The countries, of course, covered, as I think Suraj will be explaining much more. I'm just giving a very, very short, brief introductory remarks. The countries concerned are Pakistan, Bangladesh, Nepal, Sri Lanka, and India. And the handbook is organized into five key parts, compiling chapters that explore various facets of sex and gender based in disparities. Part one, which is the the sort of lays out, it lays out the whole first traces the beginnings of scholarship and activism on sex, gender, and health, including South Asia. It lays out the key sex and gender concepts and then contextualizing them in the various histories and politics of the regions. Then the different frameworks. We've read, lots of frameworks have been mentioned in the volume in chapter one. Frameworks for to integrate a sex gender lens into understanding of health, focusing on intersectionality, socio-economic approaches, social, social, socio-ecological approaches, socio-ecological approaches, social and structural determinants, and rights-based approaches. So these are all being discussed in this first part of chapter of section one. Then, of course, the part two, I'm just, this is of course just from the book itself, is the, just for others to know what it is about. Part two is a compilation of chapters addressing disparities in health status stemming from gender and sex and gender differences. Part three focuses on gender related issues within health systems, covering various aspects like the health workforce, inequities in access, affordability and quality of services, and instances of implicit and explicit discrimination in service delivery, in health delivery. Part four discusses gender inequity analysis of current policies and programs, as well as strategies for developing gender responsive policy making and programming. Part 5 focuses on advocacy, activism, and social action, describing interventions in policy programs and social movements, initiatives that have effectively addressed gender disparities in health. I mean, actual instances of where interventions took place and they were successful. Now, this diverse collection of chapters, authored primarily by individuals from South Asia, emphasize the intricate relationship between sex, gender, and health. No doubt, there's an increasing now. To me, it seems. I mean, just sort of not that I've done a lot of reading recently, but it seems that it is increasingly being recognized that gender is a significant factor in influencing women's health outcomes. So this slowly taking shape, and I think, it's, as I said earlier, it is because of this very concerted and, to me, a passionate effort of the people who are behind it. So what is important to understand is that it's a handbook. I think that's the thing I want to emphasize. It's a handbook, and I'm sorry to say, maybe I'll make a silly joke. It's not very handy to handle, but it's a handbook which has all the requirements of a handbook, and that's why it is so important, because you have the tools. The tools are there. You see, most importantly, the tools are there, and to be and to enable you to know how to integrate a sex and gender lens into the understanding of health, and a wide range of evidence-based studies. There's a whole range of studies, COVID and elderly, the disabled, the surrogacy, and I mean, there are a whole lot of them. I'm not remembering that. It's numerous chapters. I think addressing almost every dimension of health. I was trying to see, is there anything been left out? I was trying to look at that. And to me, it seems that perhaps one thing you mentioned in your chapter about the out-of-pocket expenses, but I thought this whole recent commercialization, privatization of health, and the technocratization, the technology that is coming in, and that adding to the expenses plus all the other problems, how did that impact on women? And that's one thing which probably I thought I could see, which was a little bit missing. But you have gone to every minutest dimension of what could be impacting on health. And so it's very evidently of immense relevance to all development practitioners and researchers, really of immense relevance. And I can say that this development practitioner, when she was practicing, we did actually take into account the gender impact on health, on women's health, very much. And in the 11th plan, is when we first came to the planning board in 2006. One of the we were of the opinion that we should not do everything on women immediately. Let's go step by step. And the three or four important issues we picked up. One was, of course, employment and livelihoods. Second was violence. And third was, occupational health. I thought that probably is also a little lacking in here. Like we have those very large traditional industries in Kerala, coir, handloom, cashew, each one of them has a very specific health implication for women. So that was why we had tried to, focus on that to sort of apprise or to make the policymakers aware of how much neglected that area was, because those women were really poor and really suffering. So that is a thing I just wanted to say. And in the end, let me also say that I'm very happy that CDS considers that age is no barrier, or age is just a number. And therefore, I have got this opportunity of stepping into the director's shoes for one day at least. So thank you so much. And I hope I have given you at least a flavor of what is contained in the book. Now, I could request the moderator, or you will request? Oh.
Thank you, ma'am, for that inspiring remarks. So now I request Professor Suraj Jacob to come and moderate the event. It's a really honor to welcome you to the event.
So I'll just invite Dr. Sundari Ravindran to come and, as the editor-in-chief, start. So we have planned a series of brief snippets from different people involved with the book. So she is going to introduce the book and introduce also, I think, the speakers to come ahead. Please, Sundari.
It's an honor to meet Sundari ma'am to this event. So Sundari Ravindran is TK Sundari Ravindran is an alumnus of the Center for Development Studies, where she completed her PhD and also served as a faculty member. She is currently the senior editor of the international journal Sexual and Reproductive Health Matters. She retired as a professor of public health at the Sri Chitra Tirunal Institute for Medical Science and Technology, Trivandrum. Sundari ma'am's research interests include social determinants of health, gender and intersectional inequalities in health, and sexual and reproductive health and rights. She has been a researcher, activist, trainer and editor at the local and international levels for nearly 4 decades. It's a really great honor to welcome you, ma'am. Please come.
Respected Chairperson Mridul, and dear friends, it's an honor for me, an alumnus of CDS, to have been given this opportunity today to introduce the Springer Handbook on Sex, Gender and Health, Perspectives from South Asia. It is my esteemed teachers in CDS who shaped me into a researcher engaged with socially relevant issues. On behalf of the editors and authors of this handbook, I would therefore like to thank Mridul for presenting the introductory remarks, the director, Professor Veeramani, and Professor Suraj Jacob for inviting me to introduce this handbook and making this event possible. And a very special thanks to the PhD scholars who engaged with many of the handbook's chapters in their reading groups. Before I get started, I would like to focus on the handbook's title. Why have we called it Sex, Gender and Health and not just Gender and Health? Because unlike other sectors such as education or employment or care work, where gaps between girls and boys, women and men may be attributed to socially constructed differences in opportunities, access to resources, and to power, in health, Biological differences between sexes introduces an additional layer of complexity. So, as Mridul already mentioned, the biology and the social interact to create additional risk factors, exposures, vulnerabilities, and also access to healthcare services and ability to influence policy. The female of the species has been observed to have biological advantage, not just among humans, but more broadly. And because of this, equality, for example, in life expectancy or infant mortality, is in fact a manifestation of the laws of biological advantage because of gender-based inequalities. So it is not like, is there a gap? No, there is no gap, therefore there is no inequity. There is. So it's a bit more complicated than other areas. And in this handbook, we tried to look at the biology, the socially constructed, and the intervening of the two, in addition to other layers, as I'll tell you in a minute. This handbook, while intended for public health professionals, is relevant to all development practitioners, as Mridul already made that remark, as well as those engaged in public policy making, because this handbook is informed by the understanding that health, well-being, and inequities therein are determined by social, economic, and political factors beyond the health system and the health sector. So if you're a development practitioner, beware of the health impact of the development policies and programs that are being created. The handbook defines gender beyond the binary, not just male and female, but the spectrum. It adopts an intersectionality lens, exploring how gender is enmeshed with many systems of oppression, which together impact health and well-being both directly and indirectly. The handbook does not stop at examining differences and inequities in health outcomes, but has entire sections devoted to the gendered and elitist nature of health systems, the gender and equity blindness of health and other public policies which contribute to perpetuating health inequalities. To drive home the point that policies are not made just at the top, we have chosen to introduce an entire section here showcasing community mobilization, social activism, and advocacy at multiple levels to influence and pressure policy changes. The structure of the handbook, Mridul has already told you, it is divided into 5 sections, and each section focuses on one major area, as already been pointed out. We start with laying out the concepts and also giving a feel of the health system and the gender context in each of these countries in South Asia, and then go on to talking about health and gender differences in these, sex and gender differences in health in these countries, and health systems, and how the entrenched gender inequities and the classist and casteist nature of health systems impacts on health and well-being, health policy section, and the advocacy section. So there is the handbook. It is an epitome of 56 chapters and 1,365 pages, divided into 2 volumes. A team of 12 editors worked on this non-funded project, giving generously of their time for over 3 years. The editorial team issued a call for abstracts targeting early career researchers. We reached out to activists who usually do not write for academic publication because it is not their priority. We also searched widely to identify authors who were working in those under-researched areas. It was quite a difficult task. We also had to find authors who adopted an intersectionality lens and we're not just examining, say, sex differences, which is what the majority of the research in this region focuses on. So we have 120 authors and 100 reviewers went through these papers, the 56 chapters, meticulously and gave very constructive, repeated reviews and remarks, which helped the authors revise their papers. There were authors who would give up because many of them were early career researchers. And so then the section editors would engage with them on a one-on-one video call or a Zoom call, walking them through the reviewers' comments, explaining that these are actually quite simple and just because it's 5 pages doesn't mean it is impossible. And came out, the result was really, worth all the effort. And you will see that the chapters speak to these efforts that have happened. Overall, I could say that this handbook represents a labor of love of many, many, many people who gave tirelessly of their time. They were very generous and very constructive in the way they engaged with the whole thing, and they made this handbook possible. Thanks once again to everyone who is here to look at the handbook. I hope you will find this interesting. To those of you who would like to have chapters of this handbook, I will request later that my email ID be shared in the chat, and individual chapters can be requested, and I'll do my best to get these to you. Thanks once again for this opportunity.
Thank you, ma'am, for your remarks. We will now have our first speaker, Shubhashri Balakrishnan. Shubhashri Balakrishnan is an obstetrician with over 2 decades of experience working with the community organization and health systems to improve women's health in India. Her work experience ranges from the grassroots to the state health system and international organizations. She has worked for over a decade with rural Women's Social Education Center, a Dalit women's organization in Tamil Nadu, with the state RMNCH plus A unit of Bihar, strengthening comprehensive emergency obstetric care in government district hospitals in the state, and was a senior technical officer in India for Center for Maternal and Newborn Health, Liverpool School of Tropical Medicine, and serves on the working groups of WHO and other organizations. She currently works with Common Health, a coalition working on reproductive health and safe abortion issues across several states in India. We welcome you, ma'am.
Thank you. Well, I hope with this podium you can see me and also the slides. So just go back. You would have the change here. You would have changed. Okay. Okay, so I will just be introducing to you section 2, which is titled How Sex and Gender Influence Health and Wellbeing in South Asia. Next slide, please. I'm one of the section editors along with Professor Sundari and Professor Sivakami of TISS. Now, this section, as has been said earlier, focuses specifically on how sex and gender affect health. And specifically, we look at differences or inequalities in health in terms of incidence and prevalence, health seeking, access to care, health outcomes, and also social consequences of illnesses. Next, please. So the section is basically structured as... Sorry? Yeah. So it is basically structured as an overview chapter which starts off the section. And then it is followed by 18 chapters, which are focused on the themes of the section. And of these, I have a breakup here of, which country. So India has about eight chapters focus on India, 4 are from Bangladesh, 3 from Sri Lanka, 1 from Pakistan, and 2 actually focus broadly on the region itself, on the South Asia region. Next slide, please. Okay, so in the overview chapter, what we have tried to do is to synthesize the evidence that is currently available on sex and gender-based differences and inequalities in health. Now, we've taken a life cycle approach, basically covering the different life stages of girls and women. We have a separate section on trans persons because the evidence on, many of these studies do not actually have any data or evidence on trans persons, but we wanted to include that. So we've tried to pull together the evidence that's available there as a separate subsection. Now, most of these studies that form a part of this evidence synthesis predominantly cover differences in the nature and extent of sex differences in health status. So, in health status and outcomes, basically they focus largely on measuring and describing sex, that is the male and female, as a correlate or predictor of health outcomes. Most are quantitative, a few have used mixed methods. Now, while these actually show an observed difference in male-female difference, most of the evidence has a very limited understanding of what the gendered pathways and mechanisms that underlie these differences are. And there is a very limited focus on marginalized communities. So this was a big gap that we actually found in our evidence synthesis. So the other chapters in the section are actually an effort to try and address this gap to the extent possible. So most of these chapters take a closer qualitative look at various groups and various communities and various issues. Almost all of them take an intersectional perspective, and they use qualitative methods and some use mixed methods. Most of them use qualitative methods. So over the next few slides, I'll try and give you a bit of flavor of how these chapters actually try and address the gap, and just give you a flavor of some of the chapters. So some chapters actually look at topics that are well known, well researched, but from the perspective of marginalized communities, which is not often where the evidence that's available is. So, for example, maternal health is something that has a lot of evidence already on. But the chapters that we have here are 2 chapters that focus specifically on vulnerable communities. So, there is one that looks at the experiences of migrant women in Gujarat and their childbirth experiences and the intersections of gender and poverty along with their migrant status. There is one chapter which is actually set in a conflict situation in Assam and looks at women's experience of childbirth there and how gender, ethnicity, religion, and poverty all intersect in a conflict setting to influence women's health outcomes. So these are 2 chapters on maternal health. Next slide, please. Then there are well-researched areas like abortion, but newer dimensions that are explored through these chapters. So there's this one chapter from Pakistan where abortion is actually legally restricted, and how gender norms and gender-based inequalities actually play a role in access to abortion services and post-abortion care in such a restrictive setting. Next slide, please. Then we look at women's lives beyond the pregnancy and childbirth, the usual periods that are studied, to look at the other life stages of girls and women. So one of the chapters is from Bangladesh, from Cox's Bazar, which looks at adolescent girls and boys from the Rohingya refugee community there and the Bangladeshi host community, and looks at their sexual and reproductive health and how the experiences are gendered. There is another chapter that uses the data from the longitudinal aging study of India, the LASI study, and looks at elderly women and how the intersections of gender, caste, and class influence the activities of daily living among this group. Next slide, please. Okay. Then there are specific chapters that look at specific health issues, but again, of marginalized communities. So, for example, there is one chapter from Tamil Nadu, which is known for its supposedly well-functioning health system. It looks specifically at Dalits with diabetes. and how they cope with the disease, and how gender and poverty actually intersect to influence their coping mechanisms and also their access to healthcare. There is another study from Karnataka that looks at lived experiences of trans persons and how gender identity then becomes a determinant of mental health in this community. And what is unique about this chapter, it's actually the study was led by a person from the community and also written, first author is a person from the community. Next slide, please. Then there are chapters that focus on specific contexts and how gender and health plays out in these contexts. I already spoke about this chapter from Assam, which focuses on maternal health in a conflict situation. There are several chapters that are situated within COVID. I've highlighted a couple here. So one is on commercial sex workers in Sri Lanka and how the pandemic impacted them, and how sexuality and gender then intersect to produce these impacts. Another one is set in urban Mumbai and looks specifically at older women and their lived experiences of the pandemic, and again how the intersections of gender, age, and other vulnerabilities influence their lived experiences. Next slide, please. Work is, ma'am, you said about occupational health, but we do have several chapters that take a work lens to some of these issues. So the chapter on migrants and their childbirth experience actually again it takes a work lens. The one on sex workers in Sri Lanka also does that. There is another one from that is focusing on the broader South Asia region and on women workers in the garments and textile industry in this region, and how the gendered burden of both care work and the work in the textile industry affects their health. Next one, please. Then there are less well-researched areas that we wanted to include, and I will just give you two or three of these over the next slides and then stop. So the first one is on masculinity. There is a chapter from Dhaka slums during the pandemic on how urban poor men experienced the pandemic, and Professor Sabina will be talking a little more in detail about this chapter. The second one is again from Bangladesh on men with tuberculosis and how the disease affects their sense of masculinity and their sexual lives. Next slide, please. Another area that we've looked at is at newer medical technologies and how these actually bring in newer ways in which gendered impacts are produced. So one is on surrogate motherhood. Most of the research on surrogate motherhood is not from the perspective of the women who actually undergo the surrogate pregnancy. So this one is an ethnographic study that looks at women experiencing surrogate motherhood. And it brings again a nuanced lens, including a work lens, to analyze their gendered experiences. Another one is on women living organ donors and how patriarchy and gender actually influence their decisions to either donate their organs, and then how it influences their experiences with the healthcare system. Next one. And the last one that I want to highlight is on climate change. So again, there is this chapter which focuses on Dalit communities in Bangladesh and how climate change has affected their lives, how rising heat and other shifting weather patterns have affected their health, their livelihoods, their food sources, and how then gender and poverty actually produce these intersectional effects. So to summarize, basically, therefore, we have this section actually tries to cover a diverse kind of range, which and try to bring in layered evidence to actually fill the gaps that we found in the evidence synthesis. Most of the chapters are built from lived experience. Try to bring in voices from the margins, and also take an intersectional perspective on the health consequences of inequalities. So I'll stop there and invite Professor. Should I play the video of Sabina? Yeah. So Professor Sabina will be talking about one of the chapters. So I think you're going to be introducing her.
Thank you, ma'am, for that overview of the book. Now, I invite Sabina Faiz Rashid, Professor Sabina Faiz Rashid, to talk about her section. And she is a critical medical anthropologist, and her interests are community-based participatory research and ethnographies. She is a chair of health and poverty at the BRAC School of Public Health at BRAC University, Dhaka, Bangladesh. Now, I invite her.
Yeah, hi. I'm just putting the video on in case the internet goes funny.
Just tell them we are sharing. Hello, ma'am. We are sharing your video from our side. Is that
Please do.
okay? Yeah,
Please do. Thank you.
Thank you.
Good afternoon, good evening, wherever you are. My name is Sabina Faiz Rashid. I'm professor at the BRAC James P. Grant School of Public Health. I co-wrote this paper with other colleagues, and it was led by Ishra Jahan. And it's really about men's experiences during COVID. So it's called Lockdown as a Kick to the Stomach and Ego, Narratives of Masculinity and Stress During COVID-19 Dhaka Slums. So a couple of key points. I think when we look at gender, we look at it in a very binary manner. So women are oppressed, men are the oppressors. Very rarely do we use a global southern lens or other lenses to understand what it means to be a man and to be struggling in endemic poverty or living a life of insecurity. So if you bring in intersectionality, which is class or caste or ethnicity, poverty, economic status, then you get a more nuanced picture of what it is like to be a poor man, a man living in poverty in Dhaka informal slums. So really the book is about what does it mean to be a man in slums? And one, there is not one man. There's diverse forms of masculinity. And of course, gender roles and power relations reinforce certain kinds of behaviors. But there's also a lot of pressure and stress and anxiety to be poor, to be expected to be a rice winner for the family, and then not being able to provide for the family. So one main point is that gender is not this homogenous category. It's very diverse. Masculinity is fluid concept, so it isn't like men, toxic, oppressors. I think we need to look at privilege, class, politics, economics, when we try and assess men and women and their gender dynamics. So this chapter really lays out the vulnerabilities experienced by men, younger and older, in different ways. When there was a lockdown and no one could work, many of them had small businesses, were daily wage laborers, they were young students, and basically their lives fell apart. For a lot of the men who were supporting their families, it was a huge worry about how will I feed my wife or my parents or my children. And the expectation is men need to work to earn. Now, in reality, there's a lot of women and men working because the situation is quite dire and quite precarious in slums. But there was a lot of, men of different age groups talked about shame, anxiety, sleeplessness, stress, worries about not being able to fulfill their roles. Then you had young students. You have to think about it. They live in urban slums. Urban slums by nature are neglected by state. This could be India, this could be in many parts of the world, but in Bangladesh. So they're often considered illegal settlers. They don't have basic services. You've got 4 million estimated sort of households living in about 5,000 slums in Dhaka city, which has the largest lot. So here you have young students, for them, it's a huge aspiration. They could be the first generation going to high school or college, and suddenly there's no money. If you have a university and colleges that shut down for over a year, 2 years, what's going to happen to them? Here are young men who are trying to get themselves out of poverty, and they're stuck in this cycle because lockdown didn't mean there was necessarily a national stimulus package for everybody. So you had some families that had money, some families that didn't get money, some families that had savings, some families were reliant on local leaders and power structures. So what I wanted to say in some key points is that we often forget about men, poor men, or men who live on the margins and their experiences of masculinity. We, in a global southern lens of knowledge or fieldwork ethnographies asks us to interrogate certain fixed gender categories and binaries, because there's assumptions about privilege and not every man is privileged. There's a hierarchy even within countries and across countries. So I think that's important because privilege and politics play a huge role. Second point is we need to understand context. Context matter. So if you're looking at informal slum settlements, these are extremely precarious sort of sites where residents, can live one day and next day they could be evicted. Jobs are erratic. You can have daily wage labor or daily wage laborer work, or you may not have any job for months. During COVID, people had no work and they couldn't leave the slums because the police and the army enforced lockdown. For us as the middle class, I was fine. I was working from home and getting my salary. For people who live off daily wage labor, it was the fear of starvation. And for many men, the primary sort of anxiety was, we need to earn. Who's going to feed my children? How's my wife going to survive? So I think this is very important. Context matter when we try to understand gender, identities, roles, and responsibilities. And my final point is that social science methods are very important to understand some of these nuances. Otherwise, you get a very generic, homogenized view of men and women. But these nuances tell you about the different age groups and their experiences. And some who have more power, some have less power in terms of social networks. But ultimately, I don't think you can, while masculinity and social norms and gender norms about, there was violence, there was backlash, there was fights. Men talked about not being able to cry, not being able to sleep. But a lot of this is entangled in not only gender, cultural, social norms, but also endemic poverty. So we really have to take a step back as we try and understand masculinity in its diverse forms in Bangladesh, but also in the South Asia region. Thank you very much.
Thank you, ma'am. We have our next speaker, Anjana Bhushan. She has spent 24 years at the World Health Organization. She has provided technical leadership and evidence-based evidence to WHO's member states on integrating gender-responsive, equity-enhancing, and human rights-based approaches into health policy and programs on tackling gender-based violence against women and girls. She has also worked on issues of poverty and gender in health, and more broadly, development across various international agencies, including the World Bank, the UNDP, and the ILO. She started her career as a member of the senior civil service in India, where she managed development programs across a range of sectors for 10 years with the government of Rajasthan. Over to you, ma'am.
Thank you so much, friends and colleagues. It's an honor and a privilege to be here today to share with you some insights about the third section of our handbook, which focuses on health systems. And I'm going to give you a bird's eye view of how this section is laid out. So could we go to the next slide, please? So in designing or putting this section together, these are some of the questions that we set out in the beginning to try and answer. We were interested in looking across the different building blocks or aspects of the health systems and how gender influences not just the building blocks themselves, but how they interact with each other. So, for example, what were some of the gender-based inequities in terms of accessibility, affordability, acceptability, and quality of services? What about implicit or explicit discrimination as services are delivered through providers or through biases that are hard-baked into the way the health system is designed? We were interested in health workforce issues. There are many gender issues there, but also health professional education if possible. We wanted to look at health financing as well as the role of the private sector. we'd like to go back, please, one slide. Yes. And all of this, as my previous speakers have also mentioned, through the relevant intersectional lenses. And the attempt was again to focus on marginalized populations. Next slide, please. As with all chapters as with all sections in this handbook, section 3 starts with an overview chapter. The first part of this overview chapter briefly discusses some common frameworks in terms of how to think about health systems, the key among them being WHO's well-known health systems building block framework, which has 6 different building blocks, and also its adaptations and more recent updates. We also looked at the Right to Health framework, which is encapsulated in this acronym AAAQ, which I mentioned in the previous slide. And we looked at the RINGS Consortium framework on gender equitable and transformative health systems. How can health systems themselves be more equitable, and how can they transform gender inequalities? Then a big chunk of this overview chapter looked at the regional evidence in terms of how do sex and gender interact in influencing access to and use of health services. We tried to look at gender issues in quality of care, especially through the lens of facility-based pregnancy and delivery. We looked at gender issues in the health workforce and what the regional evidence there says. And finally, we did look at specific modalities of healthcare financing and how gender speaks to them. And we gave also an overview of the 16 chapters in this section. Now, after the section that Subhashri described, this is the second largest section. It has 16 original papers. Next slide, please. So these are the 16 papers. They cover, as you can see, mostly India, but a sprinkling of other countries in the region. We had 3 papers from Sri Lanka, 1 from Bangladesh, 1 from Pakistan, and 2 papers have a regional perspective as well. You'll see also that in terms of the building blocks, most of our papers focus on different aspects of service delivery, but we do have papers on health workforce, 1 on health financing, 1 on health information, or more specifically data for decision making. And 2 of the chapters touch on governance issues, including laws and policies that may or may not be gender responsive. Across these 16 chapters, what is the health issue or disease or health condition that is used as the entry point? More familiarly, 6 of the chapters look at the health system through the lens of sexual and reproductive health and rights. 4 papers look at communicable or infectious diseases, and 1 of them through the lens of an NCD, namely cervical cancer, which is also a dimension of sexual and reproductive health. And as with the other sections, as you've heard, we have a range of methodological approaches, mostly qualitative. We have ethnographies, we have lived experiences and voices from the marginalized groups. We have many mixed method papers, but we also have a statistical analysis type paper in the health financing area. And this is the range of marginalized groups that the whole section covers. We have intersex persons, transgender persons, including multiple marginalities of transgender people who are Tamil and Muslim in Sri Lanka. We have remote upcountry tea estate women workers in Sri Lanka. We have tribal women in India and persons living with disability. Next slide, please. So like Subhashri did, I'm going to give you a quick run through of some of the new and not so new findings with regard to different health systems areas. The first being access to and use of services. So we have this very interesting paper on PMTCT, or the prevention of mother-to-child transmission of HIV/AIDS. And we look at how serostatus within couples interacts with the gender power dynamics between those spouses to influence the extent to which PMTCT is adopted. And this paper finds that men's desire for children can actually strengthen their traditional control over sexual decision making and increase the risk of interpersonal violence and extramarital relationships, thereby weakening women's agency and their opportunities to engage in HIV prevention. So obvious policy implications there. Similarly, an intra-household lens is taken in the paper from Pakistan, which focuses on vaccine refusal or acceptance among Pashtun families. And they find that factors like location, whether rural versus urban, ethnicity or being Pashtun, poverty, the gender norms around low mobility and seclusion, the resultant low access to information among women, and traditional fears about infertility constrain acceptance of vaccines. But the paper also documents examples where mothers assert their autonomy, sometimes to defend acceptance of vaccines and sometimes to insist on their refusal. We have a paper from Sri Lanka focusing on the familiar area of abortion, but it looks at how the criminalization of this abortion interacts with its stigmatization in health systems or healthcare systems to hinder women's right to bodily integrity and thereby their sexual and reproductive health. And it examines how both high costs of seeking care, especially in the private sector, as well as the patriarchal attitudes embedded in the healthcare system, particularly affect women from rural areas, from ethnic minority groups, those who are unmarried or unemployed, and survivors of intimate partner violence. Similarly, we have a very interesting paper looking at behaviors, attitudes, and practices of health professionals towards women in labor rooms in India, which finds that the combination of gender blind policies within these hospitals and a health system culture that paternalizes and infantilizes patients, that kind of a medical model results in attitudes and behaviors that can comprise actual mistreatment of women, such as trivializing their need for privacy and confidentiality, breaching of informed consent rather than observing it as a rule, and denial or normalization of their own aggressive conduct, and as well as victim blaming. Next slide, please. Similarly, we have a paper from Sri Lanka, which suggests that colonial era plantation-based health services were either inadequately integrated or inadequately upgraded within the national health system. And this produced unique geographical, financial, language, and gender-related barriers that now compromise upcountry tea estate women's access to SRH services, and this was particularly seen during COVID-19. And the impact was unintended pregnancies and increased intimate partner violence. We have another paper focusing on tribal women in Chhattisgarh, India, with cervical cancer. And here again, we see the interplay between gender unequal norms and roles, the initial reliance of these women on traditional healers, and the interplay with an insensitive and gender unresponsive health system, leading to three types of delays: delays in care initiation, delays in contacting the formal healthcare system, and delays in diagnosis and treatment. We have a very interesting paper on men and women with disabilities in Bangladesh. It looks at gender differences or differences between men and women, and it has some really interesting findings. For example, a larger share of men than women with disabilities report that their disability impacts their intimate relationships. But a larger share of women with disabilities report actually facing sexual and reproductive health issues and success in accessing services. And men and women, the chapter documents how they have different perceptions and coping strategies related to intimate relationships. And so disability, social perceptions, their economic status, and dynamics, gender relationship dynamics, affect these men and women differently in accessing services when they need them. Next slide, please. We also have a series of chapters on sexual and gender minorities. A very interesting paper on the transgender community in India documents how they face barriers in access to healthcare that include infrastructural and geographical constraints, but also the limited knowledge and competencies among providers, almost ignorant about the real issues of this community, and the traditional hierarchical, patriarchal, and unequal patient provider relationship, as well as the cis-normative healthcare system culture. How do trans people cope with this situation? They end up tolerating lower quality of care. They may adopt visual conformity to their birth gender to prevent discrimination. They may seek to selectively disclose their identity to access appropriate forms of care. They may avoid or delay care. They may source alternative solutions, including self-care. Similarly, we have a paper on intersex people in India, one of the least researched areas in sex, gender, and health. And this paper finds how a biased, namely a binary and a conflated understanding of sex and gender within the same heteropatriarchal society, as well as ableist perspectives, affect how how intersex people and their families experience or interact with the health system. It also explores the intersectionalities of caste, class, and bias and ignorance among providers, and how these lead to inequities in access, as well as adverse psychological, social, emotional, mental health, and well-being outcomes. You find that providers often characterize intersex variations as disorders, and policies unhelpfully define intersex as a subcategory of transgender. And the authors urge medical science and training needs to include these issues as not binaries or rigid. And we have another paper, as I mentioned earlier, about how Muslim and Tamil people belonging to queer communities in Sri Lanka navigate the multiple marginalities that they face and sometimes manage to create meaningful spaces at the interface of legal discourse, which in Sri Lanka criminalizes homosexuality, and medical practice, which is marked by stereotypical attitudes. The author insists that these articulations by the queer community are very critical interventions in changing dominant paradigms in biomedicine. Next slide, please. I'll just touch on a couple of papers related to the health workforce. We had 2 or 3 papers on community health workers, and we had 1 or 2 on, we have a paper on dentists, which you'll hear more about just following my comments. And we also had a paper on providers in medical colleges. So on the community health workers, there was a COVID-19 based analysis of ASHAs in Assam's floodplains and how their gendered vulnerabilities increased during the pandemic. And they responded through various forms of negotiation to be able to continue with their jobs and to assert their identity. For example, they referenced the Hadith or the Islamic principles of community service and greater good, or they asserted gender norms of good motherhood. So drawing on traditional norms and cultural ideas to be able to continue. And the chapter also documents that they remained motivated by the opportunity to achieve financial independence. A regional paper looking at India and South Asia looks at the feminized cadres of community health workers in the whole region and how these mirror gendered hierarchies and ideologies. These cadres are typically inadequately trained, overworked, underpaid, or unpaid, and face increasing digitization and surveillance. Still, it's heartening to note that they are beginning to organize, unionize, and advocate for their labor rights, and indeed to improve their status within their families and communities. I'll skip the one on dentists, as you'll hear more about this soon, and talk about how, despite claims to the contrary, we see that providers in medical colleges in India show limited understanding of sex and gender beyond the binary. They display bias, ignorance, or discomfort in providing sexual and reproductive health services to unmarried women and young people. They have paternalistic attitudes to informed consent. They normalize the mistreatment of women in labor. And they show gender bias and indeed indifference towards tackling the health needs of survivors of violence against women. Next slide, please. Just a quick word on two papers that touch on what we found in the evidence base as relatively neglected health system areas. We have a paper looking at publicly funded health financing schemes in India, which intend to target the poor, but it found through statistical analysis of survey data that enrollment was more likely among the non-poor, with poor and upper caste men having the highest likelihood of coverage. Gender dynamics tend to favor non-poor SCs and STs in rural areas and women in urban areas. Your ability to leverage the benefits and seek care after enrollment depends on inter-household caste class politics. So this is another paper that looks at the inter-household situation, and gender becomes relevant in the ability to claim these benefits. The paper finds non-poor, other backward class women, non-poor upper caste women, and non-poor SC, ST women the least likely to be covered for hospitalizations. The authors conclude that these schemes need rewiring to address gender, caste, and class dynamics. Finally, one paper looks at the so-called infodemic during COVID-19 and adopts an artificial intelligence-based analysis of digital conversations that emerge from the topmost or the rising topics from 1 year of weekly infodemic intelligence reports during COVID-19. And unsurprisingly, the paper finds limited gender-related content in the hot topics during the infodemic. The few gender-related mentions that were found tended to reinforce traditional concerns, including misinformation around harmful effects of COVID and COVID-19 vaccines on pregnancy and fertility. And this suggests that there needs to be better incorporation of gender considerations in risk communication during future health emergencies. In this particular pandemic, such communication was largely gender blind. Next slide, please. So just to conclude, we see from this section the strong message that patriarchy is entrenched across the health system and that health providers are usually ill-trained to address the needs of clients experiencing multiple marginalities. And their practice actually displays the same societal bias towards these groups. In other words, there are many missed opportunities in health system reform and many areas that require emphasis and change. And these chapters point to some of those areas. What do we think about what lies ahead? Well, looking ahead, perhaps gender-focused health systems analysis and research should pick up some of these neglected health system areas a bit more, but also continue to reflect the lived experiences and voices of marginalized women and sexual and gender minorities, as well as multiple methods, including quantitative methods of analysis, and point to more choices for and pathways to action. Thank you so much for your attention.
Thank you, ma'am. Next, I invite Dr. Malu Mohan for talking about her section. Malu Mohan completed her PhD in public health from the Sri Chitra Tirunal Institute for Medical Sciences and Technology, Tirunelveli, in which she examined the commercialization of dental education in India and its implication for dental profession. She currently works as an assistant professor under the Center for Commercial Determinants of Health at the Institute of Public Health. We welcome you, ma'am.
Thank you. Thank you, CDS and the editors of the handbook for this opportunity. May I have, shall I share the slides? Thank you. So, over the next few minutes, I would be presenting an overview of this chapter, Employment Opportunities and Career Trajectories of Women Dentists in the Private Practice Sector of Kerala, which is present in the section 3 of the handbook. So, this chapter, the core inquiry is how gender overlaps with other identities, social identities such as caste, class, and religion, to affect the employment opportunities, career trajectories, and professional circumstances of women dentists from Kerala. This study formed part of a larger doctoral research, my PhD study, where we explored the policy trajectories of commercialization of dental education in India and its implications for the dental profession in the state of Kerala. So, nested in this large study were multiple qualitative inquiries, one specifically on the professional circumstances of women dentists. Next slide, please. The doctoral research study found that Kerala was a late entrant into compared to the other states, some of the southern states. Kerala was a late entrant into the policy shift that led to the privatization of health professional education. Nevertheless, the state underwent a phase of drastic commercialization of health professional education since early 2000, particularly the dental education. So 75% of dental colleges in the state are private, and it records the 4th highest number in registered dentists. One thing we need to note about dental care services in India and Kerala is that it is very minimally delivered in the public sector, and hence the private sector is the predominant avenue of dental care and also employment for dentists. So the study found that there was a saturation due to the rapid rise in number of dental institutions and oversupply of dental graduates. Private dental practice in the urban centers of the state was experiencing a saturation that created a crisis in the practice sector that eventually leading to reduced financial viability of private practice. So this has in turn led to unemployment, poor remuneration for dentists, job insecurity, and debt in newly graduated dentists, mostly which they incurred from the education loans that they had taken to finance their private education, private dental education. So we found that all of these circumstances were much worse for women graduates. Their employment opportunity or their employment status, the poor remuneration, the job insecurity, all of these circumstances were much worse for women graduates. And women graduates, ironically, formed 2/3 of dental graduates in the state. Next slide, please. So then we found that women graduates in the state had diverse experiences as practitioners, residents, or interns with or without remuneration. Some of them were employed in other professions. Some of them were, 1/3 of them were unemployed homemakers, active job seekers, and clinic owners. So we tried to inquire how did they make sense of these experiences? And the findings emerged in 4 major themes. Endless wait for an opportunity to start their career, a sense of being deceived or cheated. Then we found that marriage as an institution had a critical role to play in determining their career. And then, of course, exclusion, differential treatment, and harassment that they experienced at their workplaces. Next slide, please. A very common theme reported by almost all the women participants was that they had to endure a long and monotonous waiting period in temporary and unsatisfactory job situations with little or very low pay until they got married. So marriage was perceived as a way out of the uncertainty, since the circumstances after marriage, including the preferences and situations of the spouse and the in-laws, determined the future career trajectory of women dentists. So there are 2 crucial points here. One is that the social location determined by intersecting identities of the women and their relative privilege determined their agency in taking or in participating or in contributing to decisions related to marriage. And second is that the extended social network constituted by extended family, relatives, friends, and in some communities, even local religious leaders or astrologers had a very strong influence on marriage related decisions of women. And the dowry practice was ubiquitous, and there was immense social pressure on women and their families to get their daughters married. So this despair was also very severe among certain social communities who were being from lower or lower middle classes, and also from communities who were increasingly being marginalized in the larger socioeconomic and political context. The second theme was that many of these women had a sense of being deceived. That they felt that they chose dentistry without understanding the full reality of the profession. Many of them were very bright, and they had lost this MBBS seat or opportunity to become medical doctors by a few ranks in the common entrance test. But instead of reappearing for the entrance test to improve their, possibilities of a medical seat, they were advised by the family and many of their peers and other social networks that dentistry is a much better choice for women because it allowed them to have more time for their families. There were less night duty, lesser responsibilities, lesser risk, and so on. But as dentists, they felt deceived because they perceived dentistry as really a lost cause, particularly for women. So there was a vicious loop: scarce jobs, poor pay, which led to and rising number of graduates, which eventually led to even scarcer jobs and poorer pay. Next slide, please. The third theme which emerged was about the critical role played by the institution of marriage in determining the career trajectories. So, being married to a dentist or a non dentist, or staying unmarried, all of these had differential implications for their career. The restrictions and opportunities to pursue the dental career after marriage was mediated by the nature of marriage, and also by the social location and the relative privilege that the women experienced after marriage. For instance, if a woman was married to a dentist, the norms, roles, and structures of dominance within families translated to clinic. That means she remained a wife in the clinic too, with implications. The dentist, the husband who was a dentist, was a husband in the clinic, and the wife who joined his practice remained a wife. So this had implications for the roles that she played in clinic, and that also had implications for the opportunities she got to grow as a practitioner. Overall, the idea was that the decisions that women take regarding their careers should always be in the best interests of the families. Now, the final theme brings out the exclusion, differential treatment, and harassment that women faced at private dental clinics in the state. Regardless of academic performance or their qualifications or their work experience, women reported that male graduates or men were preferred by the clinic owners or the chief dentists for mentoring and for assisting in important procedures, whereas they were relegated to these procedures like oral cleaning or relatively lesser important procedures that did not allow them opportunities to learn. Also, they were asked to play multiple roles in clinics which did not have much to do with their training. For instance, they were expected to be receptionists, they were expected to smile, be front office managers, cleaners, bookkeepers, and any attempt to negotiate for better opportunities to learn or pay was met with verbal abuse and public humiliation, and the argument that you may leave if you want because there are too many dentists out there for your job. So there was this general notion that women's income was supplementary and their presence in the clinic was temporary. They came and went. Next slide. So in the discussion section, we argue that gender norms, roles and responsibilities and gender-based stereotypes were major factors in determining the professional circumstances of women dentists in Kerala. And using specific examples, we try to explore how women negotiated or resisted these barriers. And this in turn depended on their social location and privilege. Next slide. To conclude, we observe that the deficient regulation of dental education sector has led to an oversupply of dentists and consequently a failing private practice sector with severe implications for the dental profession, particularly the new dental graduates. And the consequences, this manifested as depleted employment opportunities, poor career growth, gender role strain, and stereotypes. And the consequences of the situation was much worse for women graduates, and they were mediated by the intersecting vulnerabilities of gender overlapping with other identities. We also find that marriage act as one of the primary, mechanisms. Marriage being as ubiquitous as it is, acts as one of the primary mechanisms through which this unjust power sex structure is exerted and legitimized in the lives of women dentists. Thank you.
Thank you, ma'am. We have the last speaker for the day, Sara Malkani. She's an advocate at the High Court of Pakistan. She has pursued a lot of multiple human rights cases and has an extensive pro bono practice. She's been appointed as the amicus curiae by the Sindh High Court in matters involving implementation of laws for protection of women and children. Ma'am, before you start, would you like to speak or would you like the video to be played?
I think if I'm clearly audible, I'll just speak. Am I audible?
Yes, you are. So you can continue.
Yeah. All right. Okay. Thank you so much. It's a real honor and privilege to address you here at the Center for Development Studies on the launch of this landmark book on sex, gender, and health. The chapter that I co-authored is called Litigating Reproductive Rights in Pakistan. I co-authored this with Aisha Khan, who is an expert on gender and public health, primarily based in Pakistan until a few years ago, as well as Payal Shah and Melissa Upreti, who are both international human rights lawyers. And this chapter it's essentially a story of a public interest litigation that we filed in Pakistan in 2015 in order to seek enforcement of the right of women to access affordable and quality reproductive health services. So I'm going to basically summarize the account that we have provided in the chapter of how we developed this petition, what was the motivation behind developing it, what were some of the main remedies that we sought from the court through the petition, and then also briefly what were some of the successes, what were the outcomes of the petition, and then also some of the lessons that we learned regarding public interest litigation as a strategy to promote reproductive rights of women. So, as I mentioned, this petition was filed in 2015, and just kind of by way of brief background, there are severe gaps to this day on the access of women to maternal health services in Pakistan. According to the last maternal mortality survey that was conducted, I think in 2017 to 2018, the maternal mortality rate in Pakistan is 186 deaths per 100,000 births. So the death rate is quite high, and it is women from poor and marginalized communities who are affected disproportionately by this by this poor availability of affordable and quality maternal health services. And of course, where there are high rates of maternal deaths, there are also going to be high rates of pregnancy-related injuries such as obstetric fistula. So the idea, also just to briefly kind of touch on how this idea came about filing a petition and kind of seeing if this can work as a strategy in the context of Pakistan. As mentioned, I'm a lawyer based in Pakistan. And at the time, I was working with the Center for Reproductive Rights, which is an international human rights organization that has an Asia program. And the Asia program was working with lawyers in Pakistan and Nepal who were filing public interest litigations in courts in India and Nepal to seek enforcement of reproductive health as well as the right to maternal health. And this strategy had achieved some success in India as well as Nepal. In India, there was a landmark case in 2010 of the Delhi High Court that directed the government to implement its maternal health policies and also recognized the right of women to reproductive health services as a fundamental human right. So it was because of the similarities, both in the context as well as certain similarities in the constitutional provisions between India and Pakistan that enabled civil society organizations to approach the court in order to approach the court on behalf of vulnerable people, on behalf of aggrieved people, to seek enforcement of fundamental constitutional rights. And it was because of these similarities that the idea came to see if to use this strategy here in Pakistan as well. And so, in terms of the specific violation that we focused on in the petition that we filed, that was obstetric fistula. So most of you might already be aware of what that is, but I will just briefly explain that obstetric fistula is a pregnancy-related injury that is usually the result of prolonged obstructed labor. So during childbirth, often when women do not have access to skilled maternal care, they experience prolonged obstructed labor, and that can lead to a hole between the uterus and the bladder that can lead to incessant and uncontrollable flow of urine. And it can be cured through a surgery. But in the context of Pakistan, it is estimated that approximately 5,000 women develop obstetric fistula every year. And many of them are unable to afford at the time that we filed this petition, many of them were unable to afford surgery because surgery was not available at government-run public hospitals, and it was either available through private providers, or at the time there was one charitable hospital based in Karachi that was providing fistula repair surgery free of cost. And so the doctor who was the founder of this charitable hospital and who was providing women these fistula repair surgeries became one of the petitioners in the case that we filed. Another petitioner was a woman based in Karachi who had developed obstetric fistula during child labor, and she lived with that condition for many years in Karachi because she was unable to afford surgery, and she was only cured when she came to know of this hospital. And then the third petitioner in this case was a women's rights activist, again based in Karachi, who had done a lot of work primarily through theater productions in order to promote awareness regarding women's reproductive health and rights. And the grounds for our petition were that the widespread incidence of obstetric fistula in Pakistan, specifically in the province of Sindh, because we filed this petition in the Sindh High Court. So the widespread incidence of obstetric fistula is a result of the failure of the government to implement its policy commitments with respect to maternal health care, specifically its policy commitments with respect to basic obstetric care as well as comprehensive emergency obstetric care. So there were a number of policies that had been on paper for several years, but our ground was that they were not being implemented, and that led to the widespread incidence of obstetric fistula. And because government hospitals were not equipped to provide obstetric fistula repair surgery, women were being forced to live with this very difficult, painful condition for many years. It is difficult, and it's also a deeply socially ostracizing condition for women as well. And so our ground was that this is a violation of fundamental constitutional rights guaranteed in Pakistan's constitution, including the right to life, the right to dignity, and it's also a violation of the prohibition of discrimination on the basis of sex. And we also argued that it is a violation of Pakistan's international human rights treaty obligations. Pakistan is a party to the Convention on the Elimination of Discrimination Against Women, as well as the International Covenant on Economic, Social, and Cultural Rights. And both these treaties require that women be provided health services on an equal basis. And of course, that includes being provided access to affordable and quality maternal health services. So once we filed this petition, notices were issued to the government of Sindh through its health department by the Sindh High Court. And within a few weeks, we got a response from the Sindh High Court saying that it had implemented its policies, and they claimed that they had a number of functioning basic health units across the province that were providing basic obstetric care, and that they had a number of district hospitals across the province that were all equipped to provide comprehensive obstetric care. So in order to challenge the claims, we then underwent fact-finding missions. We selected a few of the basic health units that the government had identified, as well as the hospitals that the government had identified in its response. And we went to investigate to see what was the quality of the services being provided. And what we learned and what we documented was that in most of these facilities, maternal healthcare services were not being provided. The basic health units, for example, most of them were actually not functional at all. And the few that were not staffed with any attendants who had skills to provide basic obstetric care. And similarly, those facilities where they claimed comprehensive obstetric care, comprehensive and emergency obstetric care was being provided, we found that a number of them were not staffed with gynecologists. A large number of gynecologist posts were vacant. And once we made that submission to the court then ordered that a committee be formed comprising of maternal health experts and advocates, as well as representatives from the health department of the Sindh government, to come up with a number of recommendations that the government should follow in order to implement its policies, again, with the goal of implementing basic and comprehensive obstetric care policies that would prevent obstetric fistula, as well as improving access to treatment for fistula repair surgery. So the committees met and made a number of recommendations. And this happened over the course of several years. I'm sure you understand that court proceedings can take a very long time. And then eventually, the progress reports of these meetings were submitted periodically before the court. And eventually, in around February 2019, the government of Sindh committed that it was going to take measures to fill up all vacancies in gynecologist posts in government hospitals in Sindh, and that it was also going to staff and equip at least 4 district-level hospitals in the government of Sindh that would provide fistula repair surgery to women free of cost. The court then directed the government to file another progress report within 3 months to show what measures it had taken to meet its commitments. And at the same time, we as the petitioners were also monitoring the extent to which the government was going to implement its commitments. And in around 2021, the government of Sindh made its final submission to the court in this case, in which it demonstrated that almost all gynecologist posts in the province of Sindh had been filled, that it had interviewed for these posts, and that it had appointed gynecologists to these posts, and also that 6 government hospitals in Sindh were staffed with trained surgeons who were providing fistula repair surgery, and it submitted that by then more than 30 fistula repair surgeries had taken place. And we as the petitioners were also, to whatever extent we could, because Sindh is a vast province and these hospitals were scattered in various parts of the province, but to the extent that we could verify the information that was being provided by the government, we also concluded that substantial measures had been taken. And with that, about almost 7 years after the petition had been filed, the court disposed of the case with the observation that certain significant measures had been taken by the government. So that was the conclusion of the petition. Through this process, we were able to push the government to implement some of its policy commitments that would lead to prevention of obstetric fistula as well as treatment of obstetric fistula. And so it did kind of demonstrate that public interest litigation can be a strategy that can push the government to be held accountable for its policy promises. Of course, this process requires a considerable commitment on the part of the petitioners as well as their lawyers to consistently monitor the government's performance and to monitor whether or not the orders from the court are actually being implemented. And in this case, we did end up, in a sense, also being lucky because we had this case came before judges who were receptive to this issue, and the personnel in the health department at that time were also to some extent willing to comply with the court orders and also cooperate with the petitioners in the committee meetings that we had. So because these factors aligned, I think that was a reason that we were able to achieve some success in this petition, and we hope that it can be used as some kind of precedent for other advocates for reproductive rights and for the health of women and girls to see how they can use public interest litigation as a strategy to achieve their advocacy goals. With that, I'll conclude.
Thank you, ma'am. Now I invite Surat sir to deliver his remarks.
Thank you all for staying on. We're a little bit behind schedule, but it would be grossly unfair to not have a little bit of discussion, given the diverse and rich offerings we've had. So we'll try very briefly. Please stay on a little bit, and we'll end. Yeah, our rule here is tea outside. Yeah, I think Shraddha, please check. Yeah, understandable. Yeah. And if I can request both of you to come here just to face, it might be easier, Sundari and Shubha. And I think we have Anjana and Malu, and I think Sabina had to leave, but we have at least and Sarah is there. Sorry, five of you. So one quick thing, and please, we'll have a little bit of time for each of you to comment or ask questions. One deep thing which ran through was the gendered lens, intersectionality, and pathways, as I think Subhashri you mentioned, and that I think ran through all the presentations, and I think runs through much of the handbook. So one question I have for all of you, just who might choose to, it's a big picture question, and then we'll have others from the audience, is given, so I mean, this product, this labor of love, so many people, what Sundari was saying, 100 plus and so much. And where do you see going forward this discourse, so for example, I think you mentioned, Sundari, at the very beginning, embedding this kind of gendered intersectional approach in policy and even in communities. So there's, so the lived experience and community voices are there. But we know that outside of, let us say, certain kinds of activists in communities, many parts of our own communities are indifferent to these things. So where do you see, are you hopeful? This is a long process, but where do you see this kind of intervention? If you see this set of chapters and this huge work, do you see this in some way? How do we change those discourses? Policy making is so siloed, right? So at best, they will take some data on men and women and be done with it. Or what you said initially, some gap, right? Which is far from the nuance of the approach that this handbook, the spirit is taking. It is intersectionality, nuance, pathways. So it's not just patriarchy, as Sabina pointed out, masculinity, so many complications. So do you see over time, slowly these things are moving forward? For example, so this is just a big question, like budgeting. We've put some gender budgeting and we're done with it. So it's almost like, yeah, we've accounted for gender, in budget, but I don't think in any way senses of gender relations, especially non-binary, right, enter these spaces, both at the policy level. This is true even, I think, for Sarah's chapter, which, by the way, we happen to have read in one of our CDS reading group sessions. So yes, through the persistence of activists, courts, and so on, the obstetric fistula implementation got done. But what does it mean for the rest of society? I mean, are we reduced to doing this? I mean, so are you hopeful about wider discourses in policy and community? Is my big picture question. Yeah, that's one. If you want to respond now, either of you here or those online also, please feel free. And then we'll take, I think, others from the audience. Yeah, please.
Yeah, I'll just start off from my own kind of position as a medical doctor, a gynecologist. So I'm actually trained to look at women's health issues. But if I reflect back on what my medical education actually kind of helped me with understanding gender, it was zilch. I mean, there was practically nothing. And I mean, the education itself was so gender blind and biased. I mean, not even just gender blind, but also very biased. Now, what we hope by showcasing through a handbook like this, the importance of gender and the way that gender, along with the intersectional kind of inequities, that it has such an impact on health outcomes. It has the way it plays out, say, within health systems, within policies, etc., is with the hope that that this will become more, I don't know what is the word to use, but something that is that there will be much more recognition of gender in various arenas. For me, it would be medical education itself, because doctors who actually treat women need to have a perspective on gender, but there is really nothing that is there. There are, of course, initiatives. Maharashtra's had a very good initiative on integrating gender into medical education. So there is work that is happening, but there is no new syllabus that is coming. So Maharashtra has actually mainstreamed it at the level of the university, the medical university across Maharashtra, where gender integrated modules have. So gender is not a separate subject, but it's been integrated into medical teaching itself. Now that's a starting point, and we hope handbooks like this particular handbook and work like this will actually kind of move the discourse around gender in various fields forward. I don't know, Sundari, you want to add to that?
I just wanted to add that usually handbooks provide evidence on what is wrong, but we have also made a special effort to say, don't stop there. You can do something about it. People have done something about it, and there are ways to move forward. So I hope, we are incurable optimists to be in this field and working on such issues. So I do think things have been changing, and, I felt especially encouraged by your PhD students, I must say, by their interest and also in looking at the activism and the whole section on activism. And I think they felt very inspired, and they are leaders to come in the future. So many like them.
Thank you. If others online, yes, I think Anjana has her hand raised. Please go
Yeah,
ahead.
sorry, I didn't see the raise hand button. So, no, that's a very existential question. Just to add a couple of thoughts to what Subhashri and Sundari have said. Um, in my 30 odd years of working with health policymakers and practitioners, um, evidence-based policy making, becomes the buzzword. So I think continuing to build the evidence as we've sought to do in this handbook, uh, pushing the types of evidence that health policymakers and medical practitioners are used to seeing beyond the standard sex disaggregated, even that is not standard, but when it is then beyond that to other, the kind of approaches we've used here. um, but that said, I think evidence takes us so far, but then I think where we derive our hope from is also chapters or sections like the final one to which Sarah has contributed, and the inspiring stories about how change has also come through pressure from the bottom up. So there is the top down, but then there is the bottom up. And I think that mm, there's a slightly disheartening global atmosphere around in the gender space, but I think that we should not lose heart and continue to to have both the top down and the bottom up approaches. Thank you for this question.
Thank you. Yeah, I'm just checking. I think, yeah, I think not, yeah. If any comments or questions,
Actually, I thought I was making it clear in my introductory remarks what the usefulness of the handbook was. I don't know whether I completed the sentence, that it's a very useful handbook. Sometimes I sort of miss out when I go on to something else. I was saying it's a useful handbook, but one has to, I can't help making a silly joke that it's not very handy. But then after that, did I proceed to the usefulness of the handbook? I don't know. But I mean, the handbook is useful because it gives you the tools. Did I say things like that? I did, eh? So sometimes I forget what I've said it. So it gives you the tools. I mean, that's what the handbook is for. Your concepts are defined. If you want to, and you're told that look, health, every dimension of health has a gender and a sex impact. So and you have these framework to give it to you. You can adopt any of the frameworks. Mostly we are doing what is called social and structural determinants of health. That's what we are, and within social, gender is the most important social determinant of health. And then we have evidence-based studies where supposing I want to do infertility in Kerala, I can look at a surrogacy study here, or I want to do transgender person. How do we bring them into the fold? I can look at the study there. What is the method they used? And that's the way I looked at the hand. I mean, this is for researchers, for future policy makers. When you make policy, you have to keep gender in mind. That's it. That's the way I look at it.
Uh, Good evening, everyone. So we read the chapter on obstetric fistula and how it was like litigated. So it was very interesting when we read it. But then after that, I was just thinking about how feasible is it to go about this model of advocacy, PIL, and then getting this policy litigated. Like it is okay. I mean, it's a long drawn out effort. Like it starts, like they chose a specific thing to be litigated, and they arrived at the litigation. So regulating or making policy like this, is it feasible? Like it takes a lot of time, and how much can we keep doing this? Like, is there any other way that will work out better than keep on litigating, because that takes more time?
I hope you heard the question, Sarah. This is from Pranavi, one of our students here. Please go ahead.
Yes, I heard it. Thank you so much for the question. Am I audible? Yeah. Okay. Yes. So, I think that's a very important question, and I tried to touch on it a little bit towards the end of my presentation.
Yeah. Can you be a little, sorry, can you be a little closer to the microphone? For some reason, this time around, we are not able to hear you as well. Please go ahead.
Okay. Is this better? Or maybe if I turn my video off, because I think that it might be a bandwidth issue. So if I just turn my video off, my voice might be clearer.
Yeah, we can hear you. Please go ahead though. Yeah. Yeah, please go ahead, Sarah. We'll try at our end, but we can hear you.
I also mentioned that our success in this case was also partly because, or in large part because we had a receptive bench of judges. And we also at that time had receptive representatives in the health department who were also willing to engage with the court process and also engage with the petitioners. And often when these factors don't align, public interest litigation will often not be a very effective strategy, and it will be too time consuming and resource intensive and may not yield the fruits that it does. And I think I also mentioned that for us, we were inspired by some successes that had been achieved in various courts in India. I mentioned success in Delhi High Court, but there are numerous other judgments as well related to reproductive health and rights. But again, those successful outcomes came from, out of a percentage of a very large number of cases that were filed. So I guess this is to say that while it is resource intensive, I do think that for activists and civil society organizations, it can, who have the resources and who are able to devote extensive time to this kind of advocacy, I would say that as long as you're willing to be in it for the long term, it can yield positive results. And at the same time, it can set precedent that can have an impact beyond just your case, right? So, for example, our hope with this case in Sindh is that similar litigation will be filed in other provinces in Pakistan. And so it's going to have a wide ranging effect as well. So I do think that that in spite of the costs that you have mentioned, it's a strategy for advocates to certainly consider.
Yeah, and I recall, I think in the chapter it was mentioned that I think you carefully chose the issue, this out of many other possible issues, because of your sense of how it could the kind of demonstration effect across other kinds of litigation and policy. So
Correct.
I mean, just to add to, I think you already mentioned that. Yeah, I think Anjana, did you want to respond to the same? Yeah, please go ahead.
I just wanted to add one thought, which is, there's a whole array of advocacy or policy advocacy approaches. And I think the approach described in Sarah's chapter, we could ask the question, what is the role of lawyers in changing health policy? And is there a role? And this illustrates that kind of a question very brilliantly. Otherwise, lawyers, legal professionals, legal activists aren't a very common or natural ally in changing health policy. But then this shows you very clearly what a constructive role litigation can play and what a constructive lawyers can play. Over.
Thank you. I think Gareth, who's joining us online, had his hand raised. Gareth, are you still there? We're not able to see you on our screen here. Emmanuel, വേറെ ആരെങ്കിലും ഉണ്ടോ ലിസ്റ്റില്? Okay, നേരത്തെ ഒരു one hand was raised. Okay, we can come back. Well, let's turn to our physical audience here. Any other thoughts?
Thank you. Thank you so much to everybody for giving us this opportunity to listen to all of you. I had a quick question to Dr. Malu. Your work was so important for us to know that how vulnerable women are not only as recipient of in the health system but as care providers too. So I was just wondering, did you had opportunity to speak to those in the members of the medical associations or dentistry? How other members of the medical field look at these experiences of women dentists? Like I'm pointing towards the next step of how the functioning of the you say as a profession can as a policy we can say something. I know every research is not bent towards policy prescriptions, but still to extend your work to thank you.
Malu, I hope you could hear Shraddha's question. Yeah, I think she was on the icon, but yeah, maybe she'll get back. I think. Yeah, I see Gareth, and I think there was a hand raised earlier. But Gareth, if you can hear and you want to raise your question, please go ahead. Yes.
Sure, thank you. And sorry for the delay. My question was around the very pertinent comment about it not being so handy. Is obviously this kind of research, very broad, really rich research, but how to make it accessible for whether it's medical students, whether it's policymakers. Obviously, the handbook's there. It's not always the most easiest accessible. I don't know if the plan is for it to be open access generally, but how do you turn this research into things that will feed into whether it's medical education, whether it's advocacy work or otherwise? It'd be great to hear a little bit more on the team's plans for this going forward. Thank you.
Yeah, I'll just rephrase it. I think it was not very clear at our end. I think you're asking how can we now act on what's there in this handbook? How do we turn this into various kinds of actions? I think broadly, I think that's what he's asking.
Your question is welcome, and I think we can all start thinking about how to make this happen, because it is not for us to, we are not the only people working on this. So, please join us in finding solutions to the many issues through the many directions and other examples of mobilization and activism that have also been provided. I think so. I hope people will take this and run with it. And I have also mentioned that if you look at the table of contents and need access to specific chapters, we will make it, I take responsibility to make it available to you. Can you type my email ID on the chat, please? Thank you.
Yeah, but I think bottom line, he is also, and many of us are seeing this as an intervention, not just as a work, not just there is a documentation across, from scholars, from community members, from activists. But I think the spirit of the question is it's an intervention into how we should think about it, how we should go forward. And as you're saying, you're inviting all of us to be part of it. Yeah, fair enough.
What happened to Malu?
Yeah, Malu, if you can hear, there was a question for you. Are you able to hear?
It's on you.
Yeah, perhaps she's away. Yeah. Others, please. Yeah, we will wind up soon, but students. Okay, we'll come back to you, Dr. Eben. Yeah, especially from students, we have sprinkling of MA students, PhD scholars. Yeah. Rakhal, did you want to go for? Yeah, please go ahead.
Thanks very much for that, for this wonderful book, handbook. I was just interested in the choice of framing it as a South Asian handbook. What was the sort of thinking beyond that? The point really is that actually recently, in the last, say, couple of months, I've come across this, South Asian approach to caste, a South Asian approach to humanity. So I'm just, wondering whether this is, where this South Asian sort of framing came, and what you see as, the future for this sort of a frame.
This is was more with the identification of commonalities in the way intersectional forces interacted with gender, with caste being common to the entire area, so the caste, class, gender, religion kind of commonalities, the cultural, commonalities across that play a very important role in the way gender is constructed. And with some variations, having been under, part of the British colonial system, the legal system and the health system structures are also, somewhat common. And so we thought that bringing, working together and, presenting a South Asian perspective would be important. I would also like to say that perhaps this is the first handbook of this nature published by an international publisher that is completely edited and mostly predominantly authored by South Asian scholars. It is usually South Asian scholars invited to contribute to a smattering of chapters in largely Northern University edited volumes about Southern, regions, countries, and so on. So we also found, a lot of camaraderie in being together, brainstorming how we approach various issues together, how do we frame these overview chapter together, and so on, and felt very empowered in the fact that we could pull this off without any patronage from an external university or a team of Northern scholars. I must say this. Thank you.
Thank you for highlighting that. I think it would have gotten missed by those of us who haven't read all of it. So that it seems there's a lot to talk about in just that point, I think. Thank you. We'll wind up, but the chance for one or two of you. Yes, Aina.
Following upon the question on framing this on South Asian countries, since it's based on commonalities, were there any interesting patterns of shared successes or even shared failures that you came across on different sections? Anything interesting that you would like to highlight for us?
Yeah, anybody joining online, if you want to address, if you heard the question, Anjana, Sarah, Malu, if you're there. The question was about shared successes, failures, given the scope, the geographic and cultural scope of the book. Yeah. Maybe you should go ahead, Sundar. Yeah.
I must say that we didn't take a comparative frame to this. We were looking more for what do we have in common, not compare and contrast. And the world views were similar and the contexts were similar. So it wasn't set out, and there isn't the kind of evidence available that would even allow for that kind of a comparison. The data availability is completely uneven. even quantitative data, what we have, what other countries have, completely different, and so on. So we didn't have a comparative frame. So just to say that.
The community voices which are showcased, especially later in the book, and I think you highlighted that. That's probably also a little uncommon, maybe in handbooks of this nature. What was your experience? I mean, what was there transformation and the difficulties? They're not used to this. This is not their priority. The things you mentioned. What was happening there, and has this experience also emboldened them to go to other spaces which they might not usually go to?
I must say that for me, one of the most rewarding sections the most I learned as a person working on sex, gender, and health was in putting together that last section on mobilization, advocacy, and activism. And there were, so many different approaches, but most what a lingering impression is how people worked against all odds. So when a young friend here said it takes so long, I was just thinking that, I mean, people living with disabilities, people who are non-binary, people who are, living in the most impossible situations, have in them the optimism, the courage to challenge the powers that be, and to keep going no matter what, and to show that, paths can be created where absolutely, people who would have said it is impossible to make a path through this, they made their path through this. And that was for me very, very inspiring at this stage in my life, I must say. I came out of it feeling really good, really inspired, and very hopeful that there is so much happening around, and that therefore much more will happen in the future. So getting them to write, and these are all first person, I mean, original accounts by the activists who have been running these campaigns or who have participated in these initiatives. And so they had to write from scratch. And writing for academic handbooks is absolutely not their priority. So there was a bit toing and froing, where after 2 or 3 rounds of reviewer comments, some of them said, look, I really don't have the time for this. And, I have to do, there's so much that I have to do on an everyday basis. Whether this gets published or not, really, I mean, who cares? So, and then I think they also now see that this will be, in itself, one form of intervention by them. Some of them continue to be in touch, and we are, especially in 1 or 2 of them are part of some other advocacy activities that I'm now engaged in, and, lot to do and a lot to learn from all these efforts. Thank you.
I think we'll wind up. Yeah, please.
It's not a question which you can answer immediately. It's a thing which has been worrying one for quite some time. This whole issue of intersectionality. From the policy point of view, from the research point of view, yes, she's a woman, she's disabled, she's poor, she's scheduled caste or she's scheduled tribe, or it's a transgender. But when it comes to policy and budget, you see that the problem comes that you have everything in silos. So there's a Department for Scheduled Tribes, there's a Department of Health, there's a Department of Education, or all these things, And there's a Ministry of the Department of Women and Child Development. Now, the Women and Child Development obviously cannot meet the demands of all categories of women, whether scheduled caste, scheduled tribes, or fisherwomen, etc. Those departments have to meet the problems of these women, those departments who have the money for them. So, getting together, I don't call it convergence because that's a very it's a term which never can happen, but to coordinate the activities of different departments, to be able to do intersectional, that, from the policy point of view, you have to be just sort of a little warning that it becomes difficult from a policy point of view to do it unless 3 or 4 departments sit together and plan out. Okay? Because there's money in the scheduled tribes department, a lot of money in the ST department. Is it being used in the way we want it to be used? As we were thinking of the Women and Child Development Department. So if so, then we have to sit together with them, sit together with health. A tribal person wants, suppose a hospital is there. Tribal people come from far off places. There was a lot of suggestion on making some rooms for these tribal women, where they can stay. They come from the hills, they stay there, and they can refer to the hospital. Now, who does the room? Who builds the room? Is it the health department or the tribal department? So that sort of thing, because we came across this problem, and wherever we sat together and did things worked out. So that's sort of thing I wanted to just alert you all to. It's intersectionality.
If there are any comments on this, or or from those who are joining online, Sarah and Anjana.
May I come in on this? It's Anjana.
Yeah, please.
Just 2 quick thoughts. One is not just across departments or ministries, but within health. Things are very siloed. TB doesn't talk to HIV, HIV doesn't talk to, malaria and so on. There are many structures, interdepartmental structures at various levels of governance, from the panchayat on upwards, that are designed to overcome precisely this hurdle. And I just like to remind us all that when we talk about the social determinants of health and all the different sectors whose policies have bearing on health and well-being, we talk about a health in all policies approach. And there is a vast literature, as we all may know, on how to operationalize, what are some tools, what are platforms, what are mechanisms and approaches. So I think that offers us some ways forward. Thank you.
Thank you. Thank you, Anjana. Thanks to all 6 of you. We will have a quick thank you before we end. Do stay for tea and snacks. Those who are here physically, we can't offer that to those who are joining online. But please stay. We'll wind up now, and we'll have some snacks.
Thank you, everyone. It was really inspiring and an informative session. I thank everyone. I thank Mridul ma'am for the insightful introductory remarks. I thank every one of the speakers, including Sundari ma'am, Subhashri ma'am, Sabina ma'am, Anjana ma'am, Dr. Malu, and Advocate Sara Malkhani. It was a great honor to hear from you about the book. I thank Surat sir for delivering his remarks about the book and opening the floor for discussion. Thank you for giving us the opportunity to host this event. Thank you everyone for being here today. Thank you, Mr. Ajin, Mr. Abhilash, Mr. Sai, and Emmanuel sir for helping us with the technical and logical help. Thank you everyone. Have a great day.